Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter anyone else that's interested, the theobspod is for you. Episode 39, Caesarean Rates. Today I'm going to build a little bit on episode 30, Statistics. So if you haven't already listened to that episode, you might want to listen to that first before you delve into today's. In that episode, I talked a bit about the World Health Organization optimal caesarean section rate of 10 to 15%. At a population level, once this is reached, there's no improvement in perinatal morbidity or mortality. I then talked a bit about the NMPA, National Maternity Perinatal Audit, which demonstrates an average rate of 26% in the UK. And if you look at many units in the UK, the caesarean section rate is above 30%. Potentially, that's a lot of harm. On the flip side of this, we have the recent publication of the Ockenden Review, suggesting that low caesarean section rates, well below the average, may be detrimental and may be contributing to adverse perinatal outcomes. In Shrewsbury and Telford, their average rate in 2006 was 11.8%, at the time that England's average was 24%. Caesarean section rates are not just a UK problem. This is a worldwide issue. How to decide we're doing the right caesareans for the right reasons at the right time. It's also politically a minefield in the birthing world. Sometimes we can be seen as separating into two camps, pro-caesarean or anti-caesarean. Pro-physiological birth, or in inverted commas, sometimes called normal birth, or pro-intervention. And that would be great if intervention always meant safety. But it doesn't. When I was appointed as a consultant, I was appointed as a labour ward lead. One of the first jobs I was tasked with was to try and reduce our caesarean section rate. Caesarean sections were seen as bad, an unnecessary intervention, causing short-term morbidity for women, as well as a longer-term impact. This was in part due to the alarm at rapidly rising caesarean section rates and lack of data in the UK. This led to the National Sentinel Caesarean Section Audit in 2001, the first attempt to obtain proper data and look at reasons for variation in caesarean section rates, indications for caesarean sections, and the attitudes of women and professionals to the rates. To start to explore caesarean section rates, there are a number of issues that we need to look at. The first being why. What are the indications? Why are we doing caesareans? From the audit at the turn of the century, over 70% of caesareans could be attributed to the following four indications. Dystocia, that is, lack of progress during labour. Fetal distress, that is, the baby being stressed. Breech, the baby being bottomed down. Or repeat caesarean, a woman that's had a caesarean before. These were cited as the major determinants of the overall caesarean section rate. The main contributors being primary caesarean, so a caesarean in a woman that's never had a caesarean before, and repeat caesarean. Even at that point, in 2001, maternal request was recorded as 7%. That is, caesarean at the choice of the woman rather than for some medical clinical indication. When we think about why, we also need to think about the urgency and the decision making that goes into that why. The audit explored decision making, some of which is now a little outdated as we look 20 years on. It looked at the need to use oxytocin, that's synthetic oxytocin hormone that makes the womb contract, in a first-time labour before a diagnosis of dystocia could be made. And that doesn't fit with modern evidence that it doesn't necessarily change the outcome, it just may make the labour slightly faster. The decision-making also alluded to the need to perform a fetal blood sample prior to diagnosing fetal distress. This is outdated as the evidence for fetal blood sampling, taking a little drop of blood from the top of the baby's head, which was common practice in the past, has not got good evidence to back up that those results show the state of the baby. And so in many units, this has been discontinued. The one important aspect of decision making that does still apply is that a consultant should be contacted prior to an emergency caesarean. In the audit, a consultant was the most senior person involved in the decision to perform a caesarean in 67% of emergency cases, but there was wide variation between regions, from 64% to 87%, and between units from 16% to 100%. It seems reasonable when you're a woman about to undergo emergency surgery that the consultant should be the person helping make that decision to decide whether it's necessary. The audit looked also at different degrees of urgency and assigned caesareans to 4 categories of urgency. We still use these categories today. Category 1 is an immediate threat to the life of the mother or the fetus, the baby. These would be clinical conditions such as an abruption where the placenta separates prematurely from the wall of the womb with accompanying bleeding, cord prolapse when the umbilical cord comes down through the neck of the womb, rupture of the womb, or an active bleeding placenta previa, low-lying placenta. In the audit, interestingly, although 16% of caesareans were classified as category 1, when they reviewed the clinical features, actually it would mean about 8% of caesareans are performed for these reasons. Category 2, which is the most common emergency situation, is maternal or fetal compromise that is not immediately life-threatening. That was 32% of caesareans. And this is what we normally talk about when we're talking about an emergency caesarean. It's not an immediate threat. We think the baby ought to be born in the next hour or hour and a half. So it's not a rush to theatre, all guns blazing, immediate, we need to get this baby out. It can be done in a calm fashion, but it wasn't planned. So by definition, it is an emergency. The third category is the mother or the baby needed early birth, but there was no risk to the mother or the baby immediately. This was 18% of caesareans. And this might be a mother whose blood pressure is deteriorating and needs birth in the next day or 2. This might be a woman whose waters have broken, whose baby's in the wrong position, so she can't labour, but she's not contracting, and again, it needs to be done in the next 12 to 24 hours. The final category is what we term an elective or planned caesarean. That's birth time to suit the mother and the staff, and that's 31% of caesareans. And these are our planned booked-in caesareans, which we usually book at 39 weeks or beyond because that's the safest time for the baby. Once we've finished looking at the why, we have to look at the who. Who are we doing all these caesareans on? Many of us have commonly been using what are called Robson groups, named after a UK obstetrician. The WHO, the World Health Organization, have decided in the last 3 years to recommend Robson classification of caesarean sections to help different units in different countries evaluate the rate of caesarean birth and to try and understand what the issues are and how these rates might be improved upon. They've produced a very nice implementation guide, and if you have a look at it, it's very striking how caesarean rates across the world vary enormously, from as low as less than 5% right through to more than 30%. There's an interesting world map that shows these differences. The Robson groups are extremely helpful, dividing all women giving birth into 10 groups. The first group is women having their first baby, with a baby that's head down, more than 37 weeks, who are in spontaneous labour. Group 2 is that same group, so women having their first baby, head down, more than 37 weeks, who either had labour induced or were delivered by caesarean before labour started. Group 3 are women who've had a baby before, with a single head down baby, more than 37 weeks, in spontaneous labour, who have never had a caesarean in the past. Group 4 is women who've had a baby before, without having had a caesarean in the past, with a single head down baby, more than 37 weeks, who either had labour induced or had a caesarean before labour. Group 5 is all women who've had a baby before, who've had at least one previous caesarean with a head down baby at more than 37 weeks. Group 6 is all first time mums with a single bottom down baby. Group 7 is all women who've had a baby before with a single bottom down baby, including women who've had caesareans before. Group 8 is all women with multiple pregnancies, such as twins or triplets, including women who've had a caesarean before. Group 9 is all women with one baby who's either diagonal or crosswise transverse, including women with a previous caesarean. And Group 10 is all women with one head down baby who are preterm, less than 37 weeks, including women with a previous caesarean. So this classification into 10 means we can look at the rates and the key groups that we need to focus our attention on. Most of the time in my unit, we focus on Group 1 and 2, that is first time mums, more than 37 weeks, in spontaneous labour, or those induced, or those that had a caesarean before labour. And Group 5, those are women that have had a baby before, had a caesarean before, and have a single head down baby. The reason we mainly focus on 1, 2 and 5 is these are the largest proportion of the caesareans we do. Many units in the UK divide their statistics, their birth rates, into Robson groups to drill down and understand which areas need improvement. Following the National Sentinel Caesarean Section audit in 2001, a caesarean rate toolkit was devised by NHS Improvement with 3 clear pathways. The first pathway was to look at the caesarean rate in first pregnancies. This is because a woman's first birth is key in determining how she will give birth in the future. If she has her first baby vaginally, she's very likely to have her subsequent births vaginally too. The second pathway was women having a planned caesarean. Those who've decided ahead of time that they're going to give birth by caesarean should have a streamlined pathway so that it's efficient and planned and their recovery is maximised so that the caesarean is as safe as possible. The third pathway was Group 5, women who've had a caesarean before, and their choices between repeat caesarean and vaginal birth after caesarean, which I will talk about in a future episode. Let's take that Group 1 and 2, first-time mums in their first pregnancy with a head-down baby at more than 37 weeks. How can we maximise their chance of a vaginal birth? Well, if we turn to the NICE, National Institute of Clinical Excellence guidance, there are a number of things we should be looking at. If we look at section 1.3, factors affecting likelihood of caesarean during intrapartum care, we find that simple things like continuous support in labour reduces the likelihood of caesarean, regardless of whether that person supporting has training. We should be careful how we use fetal monitoring because it's possible that that increases the likelihood of caesarean. We should be thinking about induction beyond 41 weeks because this reduces the risk of perinatal mortality and the chance of caesarean. There are some factors that have no influence on the likelihood of caesarean, which seem slightly counterintuitive, as they include walking in the labour, not lying down during the second stage of labour, being in water during labour, use of epidural during labour, and the use of raspberry leaves. You might be slightly confused about that last one, but raspberry leaf tea to induce labour or make labour more likely has long been a natural remedy that women have used. Then there's a section on failure to progress in labour, which it does put in inverted commas, and they talk about breaking the waters or active management of labour, that's using syntocinon hormone, doesn't influence the likelihood of caesarean. The key one is the top one though, place of birth. And the guidance says this recommendation has been deleted. See updated information for details. So it's hidden. But if you click that link, then it very clearly states the issues I mentioned in the home birth episode for an uncomplicated pregnancy in a first-time mum. If you look at table 3 in the NICE recommendations of place of birth, the difference is striking. So a first-time mother planning birth in an obstetric unit has an associated higher rate of intervention, including caesarean, compared with birth in other settings. If you look at the table, incidence per 1,000 first-time mothers giving birth. If a woman plans a home birth, 80 per 1,000 will have a caesarean. And the figures are fairly similar if she plans a birth in an alongside midwifery unit, 76 per 1,000. But if she plans birth in an obstetric unit, her rate of caesarean is 121 per 1,000. That's a significant increase just from choosing to give birth in hospital under the care of obstetricians. And as an obstetrician, that worries me. What inadvertent harm we do when we're trying to do the right thing. So the place you intend to give birth is one of the biggest risk factors in terms of possible need for caesarean. Worries about the rising caesarean rate have led to good policy intentions. This has led to financially incentivising so-called normal birth, birth without intervention. This starts with a good intention, trying to reduce unnecessary intervention, but no doctor or midwife feels at that point, at that decision, that they're doing something unnecessary. They genuinely believe at that point in time they are trying to do their best for that woman and her baby. When I talk about financial incentivisation, this may be that commissioners say they won't pay above a certain rate of caesarean section. Certainly this is something I've experienced when I was leading the maternity service in my hospital. At one point there was a cap on the caesarean section rate, so that any caesarean we did above 26%, the hospital lost money on it. We simply wouldn't be paid for anything above that rate. An alternative way this has been done is changing the tariff, so that PBR, payment by results, doesn't actually cover the cost, the incremental difference between a vaginal birth and a caesarean. The price is insufficient for the relative costs. This means that the maternity unit may make more money by doing vaginal births, which are potentially cheaper, than by doing caesarean sections, which need a lot of resources, both in terms of staffing and equipment. The other situation in which the caesarean section rate becomes relevant is when you become an outlier. I've been involved in many conversations between different labour ward leads at different hospitals when they have been alerted that they're an outlier, either receiving a Dr. Foster or CQC alert. These are systems, again, which are designed to be beneficial. They're designed to show when you're doing something out of the ordinary and that doesn't fit with expected practice, and is to ensure good quality, consistent care. However, perversely, this can mean a time-consuming, laborious audit and analysis of why we're outliers to the regulator. This may take clinicians' time and energy away from women to looking at notes. It starts with a good principle to ensure we're providing a good standard of care, but ends up being somewhere completely different. I would be surprised if you could find me an obstetrician who's leading a service or being a labour ward lead that hasn't at some point had to justify why the caesarean section rate is what it is, or hasn't been asked to lead a project to try and reduce it. It's a problem that we're all tackling all the time and that doesn't have easy answers, as it's multifactorial. It's extremely difficult to make sure we're doing the right caesarean for the right reason at the right time. After all, one caesarean we should have done but didn't could cost the life of a baby or damage to mother or baby. Compare that with doing too many caesareans. That may seem like a price we're willing to pay. Then the next thing you need to link into this controversial topic of caesarean rates is the 2012 National Institute of Clinical Excellence guidance on maternal request caesareans. We're seeing increasing numbers of women choosing a caesarean birth. Many of these women are women with previous birth trauma, or women who have a fear of childbirth, or women for whom this seems like the right choice because of mental or physical health concerns. This guidance was instrumental in changing attitudes, in that at that point in time, it detailed that if an obstetrician did not agree that a woman could choose to have a caesarean, the obstetrician should refer her to another obstetrician who would be willing to do so. In effect, it was saying a woman had the autonomy to choose this as her mode of birth, and that she couldn't be refused this by a professional. Of course, a woman has a right to decide what happens to her body, but it's also ethically quite difficult electing to have surgery, which is relatively safe, but not necessarily safest. What is our role as doctors in facilitating this and educating women about what the issues are. At my hospital, we have always supported maternal choice, providing that is well informed and the woman understands the pros and cons of the choice she is making. However, some hospitals do not have this attitude, and we have had women coming from a wider catchment area specifically for this reason. You only have to look at the survey Birthrights recently did on maternal request caesarean to see that the application of this guidance is far from uniform. In my experience, when I talk to women who want a caesarean, the too posh to push mantra is an unhelpful and judgmental way to look at things. Women have often very thoroughly researched and thought through their reasons. It is extremely rare for me to have a conversation with someone who wants a caesarean just because they do. There are often complex reasons underpinning their decision. If we come back to that National Sentinel Caesarean Section audit at the turn of the century, they asked women and professionals their attitudes about caesarean, and there were some interesting and contrasting findings. About 50% of women said they had sufficient information about labour and the common possible interventions. Only about 40% of women reported they had sufficient information about the risks and benefits of caesarean, and a significant proportion of women reported they would like more information, as they'd had either none or insufficient information about the procedure. That was 48%. Women were asked to express their feelings about the birth of their baby by agreeing or disagreeing with statements, and nearly all women expressed a strong desire for a birth that was the safest option for their baby and that was the least stressful for their baby, and this was considered the most important aspect of the birth. And this is where we have to be careful, because caesarean may be safe and least stressful for some babies, but there are some benefits to the baby of vaginal birth, and the assumption that caesarean is always the safest option for the baby is simply not true. On the flip side, most, that is 80% of consultants, agreed with the statement birth was a natural process and should not be interfered with unless necessary. There was concurrence with the view that women's preferences were a priority in decision regarding mode of birth. However, consultants were more likely to agree that a woman should have a vaginal birth if she wanted than to agree she could have a caesarean if she wanted one. Yes, that data's 20 years in the past, but I don't think that has entirely gone. I think there still remains, and I see it in my colleagues, some judgment about the value of caesarean and whether or not it is a valid birth choice. Where does this leave us for our zesty bit? I think key is Group 1 and Group 3. These are women who are in spontaneous labour with a single head-down baby at more than 37 weeks. These are the women who really should be having a straightforward birth. Nature started it. High rates of caesarean in these groups suggest that we are not optimising our care of women in labour. Group 2 and 4, inductions, come back to the episode on induction about when is induction really necessary, really warranted. If you're a professional, think about what we can do to avoid unnecessary caesarean sections. Look at the NICE guidance. Think about things that do and don't impact on the caesarean rate, and look at your caesarean rate by Robson groups, as this will help you pinpoint where changes could potentially be made. Examine your own bias about acceptability of caesarean as maternal choice. And what about if you're pregnant? As a pregnant woman, Understand the implications of the choices you make. Try not to get dragged into the rhetoric and politics either side of the debate. Natural birth, in inverted commas, versus caesarean birth. Understand the possibility of the interventions that may become necessary during your pregnancy or birth. Understand that caesarean is a real possibility. Be prepared for it. Understand what the indications might be and how you might try and avoid it. Understand the pros and cons of caesarean birth so that you're well informed if at some point during your pregnancy or labour midwives and doctors are suggesting that this is a necessary intervention for you and your baby. I do hope you've enjoyed listening to this episode of theobspod. Feel free to contact me on Twitter at FWMaternity or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the theobspod to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.